stop.
Okay. So I think we can start now. Good afternoon, everyone. So today I have been allotted this topic, adrenergics and noradrenergics. So we'll be discussing this over the next few minutes. So basically, uh, when we talk of nervous system of our body, we have central nervous system and peripheral nervous system. Now, you already have read all these things, so it's not that I'm telling something new. Then, when we talk of peripheral nervous system, in peripheral nervous system there is somatic means sensory nerves and motor nerves, and then we have something called autonomic nervous system. So, autonomic nervous system basically is a component of peripheral nervous system that regulates involuntary functions of our body or involuntary processes of our body which you or me cannot regulate ourselves, that is like heart rate, blood pressure, digestion, sexual arousal, and it actually comprises of three different sets of nerves like parasympathetic system, sympathetic system, and enteric system. So enteric system is a part of noradrenergic, cholinergic system basically, maybe. So parasympathetic nervous system, you see, you have already read in your previous classes, in your earlier classes maybe, that parasympathetic nervous system comprises of craniosacral system. That is the nerves 3, 7, 9 and 10 as you already you are seeing here, and sacral nerves that are second, third and fourth sacral nerves. These together comprise parasympathetic nervous system. Now, this is the nervous system which actually lets body function normally in a state of rest. So this is the nervous system which maintains your rest equilibrium. That is, from P you can remember, P is so rest and means resting heart rate, resting blood pressure, everything. Then rest and digest. So enteric, there are nerves in your say parasympathetic nerves which primarily regulate your digestion also. Then you have sympathetic nervous system. So sympathetic nerve roots, they actually arise from thoracic and lumbar nerves. So thoracic T1 to T12 and lumbar 1 and 2, these are part of sympathetic, and means sympathetic nerves arise from these thoracic and lumbar regions. So craniosacral is parasympathetic and thoracolumbar is sympathetic nervous system. Now, where do you see function of sympathetic nervous system? So you see in the cases of fight or flight. That is autonomic nervous responses. So what is your heart rate increase? When you see something, suppose you suddenly see a snake, or someone, suppose right now I tell you that we'll be taking a surprise test. Now you don't be fearful right now, because you're all maybe away at your homes and you can write whatever you want. But still, say if in a class system some teacher comes and tells you that you'll be having a surprise test in next 5 minutes, so you're not prepared, you suddenly become fearful, you think of reasons to flee. Sometimes there is some snake in front of you, a lion in front of you, suddenly you're walking on a road and you see that, and you have fear and you have a response of flight, to run away. So all these things are taken care of by sympathetic nervous system. So your parasympathetic nervous system lets you maintain your state of rest and digestion, whereas sympathetic nervous system lets you undertake the responses of flight or fight. So whatever you are about to do, you get fearful. Now you might battle with the enemy, you might battle with that hurdle you see, or you may flight. So these are actually stress induced response. So P is S, rest. This is simple mnemonic for you to remember. Then when we talk about sympathetic nervous system, we are basically talking about catecholamines. So we have three basic types, three endogenous types here actually. So the first one is noradrenaline, or called norepinephrine. So noradrenaline or norepinephrine, that is the major transmitter in sympathetic nervous system. So you see these three, adrenaline, noradrenaline and dopamine, they're actually synthesized via same biosynthetic pathway, but then it depends on where that biosynthetic pathway terminates. And if it terminates earlier, you get dopamine. If it terminates one step later, you get noradrenaline. If it terminates on the last step, you get adrenaline. Now, adrenaline, that is mostly secreted from adrenal medulla as a major hormone. It's not that it is not present in brain, it also acts as a neurotransmitter in brain. Then coming over to dopamine, which is major transmitter in parts of brain and in some peripheral areas as well. So here in this diagram, you see what happens is there is hydroxylation of tyrosine. So this tyrosine is taken inside the nerve terminal along with a sodium ion. Now this tyrosine is converted to dopa, and that is converted to dopamine. Now when this dopamine enters synaptic vesicles, now what does it form is norepinephrine or adrenaline. Sorry, norepinephrine or noradrenaline. Now norepinephrine and noradrenaline both are synonymous. So this is formed here. Here you can see synthesis of norepinephrine, where hydroxylation of tyrosine converts into dopa, then to dopamine, and dopamine is then converted into noradrenaline. Now this noradrenaline, here you can see this is actually a presynaptic neuron, and this one, the yellow space you see is a synapse. So you see here noradrenaline, now the vesicle fuse with this synaptic membrane, and then the noradrenaline is released. Now this noradrenaline can be taken into the say neuron, the presynaptic neuron, again through presynaptic receptors, or it may be transferred to inactive metabolites. So it might be metabolized to, what? It might be metabolized to catechol O methyl transferase, this enzyme COMT. This will convert it into inactive metabolites, which will be excreted out via urine. So the steps in adrenergic transmission are synthesis of norepinephrine first, which is how is it synthesized? Tyrosine taken into the nerve terminal, tyrosine converted to dopa, dopa converted to dopamine, then to noradrenaline. So here you can see uptake, and the second step is uptake into storage vesicles. So dopamine enters a vesicle and is converted to norepinephrine. Now, because norepinephrine is in this vesicle, it is not degraded here. And this vesicle is then fused to the synaptic membrane, and thus there is release of neurotransmitter. Now, how is this mediated? This is mediated via calcium. So, influx of calcium causes fusion of the vesicle with the cell membrane, and it's this process you already know is known as exocytosis. Next step is binding to the receptor. So, norepinephrine, when it is released to the synaptic cleft, it acts on the postsynaptic receptors, and then it causes some intracellular response which is meant to be. Then norepinephrine is removed by either by reuptake, or it is then methylated by COMT and oxidized by MAO. So there will be two enzymes, catechol O methyl transferase and monoamine oxidase. So both these enzymes might cause its metabolism. So here you see what are the steps in adrenergic transmission. If someone asks you, there is intake of tyrosine. Tyrosine is converted to dopa, then to dopamine. Now this dopamine is uptaken by the storage vesicles, where it is converted to norepinephrine. Now this norepinephrine is released by fusion of the cell membrane with the vesicle. Then when this is released, it might now act by binding to postsynaptic receptors, or it will be reuptaken by the presynaptic neuron, or it will be metabolized by catechol O methyl transferase and or MAO monoamine oxidase. Now what happens is, here this uptake of dopamine into the vesicle is inhibited by a drug called reserpine. Then this release of neurotransmitters is inhibited by guanethidine and beryllium. So in this step of transmission, you get to know of three drugs: reserpine, guanethidine and beryllium. Next we have seen that it is formed, now it is acting on postsynaptic or presynaptic receptors. So we need to know where are these receptors present. So basically, when we talk about adrenergic receptors, we have broadly two types of receptors, alpha and beta receptors. Now we have to subclassify these alpha receptors as well as beta receptors. So first of all, make a picture in your mind that whenever someone says alpha 1, you imagine postsynaptic. In alpha 2, get to imagine presynaptic. So here this receptor is alpha 2 receptor, which is present in presynaptic neuron. Whereas on other organs of our body, the receptor present is postsynaptic receptor, that is alpha 1 receptor. So alpha 1 receptor is present on vascular smooth muscles, say blood vessels. Then on eye, it is present in pupillary dilated muscle. Then it is present in piloerector muscles, and finally in genitalia you see it is present on prostate. Okay, so coming from top down, eye, that is pupillary dilated muscle. then come to vascular smooth muscles, then to piloerector muscles, and then to prostate. So you see we have 3 P's: pupillary dilator, prostate, and pilomotor smooth muscles. Now think of alpha 2. I already told you they are presynaptic receptors. So they are present on sorry, they are present on nerve terminals, that is prejunctional nerve terminals, and also on platelets. Then I told you we have alpha 1 and alpha 2. So alpha 2 receptors, they are of 3 broad subtypes: beta 1, beta 2, beta 3. So think of beta 1 and think of heart and kidney, the 2 most vital organs of our body. So on heart, what it does is increases heart rate, increases cardiac contractility, and increases cardiac conductivity. Then coming over to kidney. On kidney, it has effect on renin release, the major effect. Then coming over to beta 2, its action is on lungs, arterioles, uterus, and other smooth muscles. And beta 3, even if you don't remember, it's okay, but then it's present on adipose tissue. So you must know beta 1 and beta 2. I'm exempting just beta 3, that even if you don't remember, it's okay, because it has not been worked on too extensively, and still we have very few drugs, say 1 or 2 drugs which act through beta 3. And now alpha and beta both have G protein coupled receptors. This is enough for you to know that alpha and beta both are G protein coupled receptors. So till now I told you we have 2 broad classes of adrenergic receptors, alpha and beta. In alpha we have alpha 1, alpha 2, where alpha 2 was presynaptic or prejunctional receptors. Alpha 2, that was present on vasomotor, vascular smooth muscles, pupillary dilator muscles, prostate, and pilomotor smooth muscles. Beta 1 present on heart and kidney. Beta 2 present on lungs, arterioles, uterus, and smooth muscles. The heart and kidney. Beta 2 present on lungs, arterioles, uterus, and other smooth muscles. And beta 3 is present just on adipose tissues. Then, now we'll be moving to drugs. The drugs which mimic sympathetic nervous system activity, that is sympathomimetics. So it will act as the endogenous transmitters like adrenaline, noradrenaline. So it will act as if we have stimulated the sympathetic nervous system. So that is drugs with action similar to that of sympathetic stimulation. They are called sympathomimetics. So we have 3 types of sympathomimetic drugs: direct acting, indirect acting, and mixed acting. So what is direct acting? Direct acting is it will act on the receptors by itself. So the drugs like noradrenaline, adrenaline, dopamine, isoprenaline, phenylephrine, they act on postsynaptic or presynaptic receptors themselves and produce the desired effect. The second type of drugs are indirect acting, that is amphetamine and tyramine. So these per se, if you put that on a receptor, amphetamine and tyramine, they will not have any effect. But what they do is they displace the neurotransmitters. You already saw there was neurotransmitter norepinephrine, that they displace the neurotransmitter from the synaptic cleft, and those neurotransmitters goes, and that neurotransmitter, that is norepinephrine, displaces from the vesicles and goes and acts on the postsynaptic membrane. So what will this do? You see here, if we take means amphetamine, tyramine, what it does is there is displacement of this neurotransmitter which is already present in these vesicles, and this comes and acts on the this comes and acts on the receptors. Now mixed acting, there are ephedrine can act both ways. It can itself come and bind to receptors and produce effect, and it can also displace the neurotransmitter which is already present in the synaptic vesicles and have effect. So direct acting, indirect acting and mixed acting sympathomimetics. Then be it direct acting, be it indirect acting, we have a therapeutic classification for adrenergic drugs. So in this therapeutic classification, you'll see system-wise drugs. So if someone asks you to write a therapeutic classification of adrenergic drugs, so this is that there are drugs which are good vasopressors, noradrenaline and phenylephrine. Then we have bronchodilators, salbutamol and terbutaline. Then we have CNS stimulants, amphetamine, ephedrine. Then we have cardiac stimulants, adrenaline and dopamine. Then we have nasal decongestants, phenylephrine and xylometazoline, oxymetazoline. Then we have appetite suppressants, fenfluramine, and we have uterine relaxants, salbutamol and isoxaprine. So I need not tell you these vasopressors. So what will they do? They are vasopressors. They'll constrict the arteries or they'll increase the blood pressures. So in cases of shock, you can give noradrenaline, phenylephrine. Then bronchodilators. Of course, there is some bronchospasm, there is episode of asthma. Then bronchodilators may be useful like salbutamol, terbutaline. Then CNS stimulants. So in cases of some attention deficit, hyperactivity disorder, etc., you can apply this drug like amphetamine, or in some cases of cardiac bronchospasm also. Then cardiac stimulants. What will they do? They increase heart rate, they increase contractility. So adrenaline and dopamine. Then nasal decongestants. So you take say nasal in cases of some rhinitis etc. You take nasal sprays. So these are nasal decongestants, phenylephrine, xylometazoline, oxymetazoline. Then some obese people tend to take fenfluramine as appetite suppressants. And in cases where you have some impending, you want to delay the labor, so you give some uterine relaxants like in salbutamol, isoxaprine. So sometimes you actually want to buy time for fetal lung to mature or something. So in those cases, you try to give some uterine relaxants like salbutamol, isoxaprine. So this therapeutic classification is nothing but actually these are based on the places for receptors. So these are based on the receptor sensitivity or say receptor location in the various organs. So the type of receptor which is present, accordingly there is a therapeutic benefit. So you already saw that alpha receptors are present, alpha and beta both are present on blood vessels. Then on lungs, what did you see? Beta receptors, or more precisely beta 2 receptors. Then on heart you saw beta 1 receptors, right? So accordingly these drugs have an action on those receptors, and that is why this therapeutic classification. Then therapeutic uses. So we already saw that adrenaline can be good vasopressor, and so it is given in 0.3 to 0.5 ml of 1:1000 solution, which is given IM. So this is its therapeutic use. Then it is also given with local anesthetics for prolonged action. So on that, the dose will be much dilute. That is 1 is to 10,000 to 1 is to 2 lakh. Then for control of hemorrhage, it is 1 is to 10,000 to 1 is to 20,000. So you can see adrenaline can be given in 3 doses for 3 different indications. So while prescribing to while actually administering to a patient, you must keep in mind, because in your emergency tray or trash tray, there might be in cart, there might be all these dilutions present, or you are required to make them in an emergency. So you should be very familiar with these doses, that there are 3 different types of dilution to be given for 3 different types of indications. So in anaphylactic shock, it is 1 is to 1000. With local anesthetics, it is 1 is to 10,000 to 1 is to 2 lakhs. And for control of hemorrhage, it is 1 is to 10,000 to 1 is to 20,000. Now, it is also indicated, dipivefrin, it is indicated in glaucoma, and then in shock, in dopamine and dobutamine can also be given in shock conditions, when actually these are given when patient is not responding to adrenaline, and then later in the course this dopamine or dobutamine can be given. These drugs can also have adverse effects like nausea, vomiting, palpitation, angina, headache, insomnia, restlessness, and also beta adrenergic drugs can have an adverse effect of tremors as well. Then, as we saw adrenergic drugs, we have anti-adrenergic drugs. So these are basically drugs which antagonize the receptor action of adrenaline. There are sympathomimetics. Now these are anti-adrenergics. So these drugs can be again of 2 types. We have 2 types of receptors. So we can either block alpha or we can block beta. So drugs that inhibit adrenergic response mediated through alpha receptors or alpha adrenergic receptors without affecting those mediated through beta receptors, those are called alpha blockers. And the drugs which will block the action of beta receptors will be called beta blockers. So you understand, na? If we are giving a blocker, what will happen is there will be no effect produced, right? So when we are stimulating the receptor, there is some effect, there is some post-synaptic changes, the adrenaline or noradrenaline or whatever we're administering that goes and acts on that post-synaptic receptors and produces a chain of events. And we already saw what all things can they cause. Now we are blocking that receptor, so there would be no effect produced. So the adrenergic responses which would have been produced in normal condition would not be active, and those things will be blocked. So if the effect won't, the stimulant effect will not be produced. Now alpha blockers. So we already saw where all alpha receptors are present. By now you must be remembering this thing, that alpha 1 receptors are present on vascular smooth muscles, pupillary dilator muscles, prostate, and pilomotor smooth muscles. Now alpha blockers can be of 2 types, non-selective and selective. So non-selective does mean that it does not distinguishes between alpha 1 and alpha 2, so it will have effect on both the places. Okay, so it will have effect on non-selective effect. So phenoxybenzamine and phenethylamine, these are non-specific or non-selective drugs, whereas selective drugs, which are so alpha 1 selective and alpha 2 selective. Alpha 1 selective drugs, they act only on alpha 1 receptors. They block only alpha receptors. They block only alpha 1 receptors. So prazosin, terazosin, doxazosin, tamsulosin. So in all these places, these drugs will have no effect. These will have blocking effect only on these alpha 1 receptors which are present on these places. Then alpha 2 selective, that is eohimbine. that will have blocking effect on these places and not on this place. Then uses of alpha blockers. So alpha blockers like are used in hypertension. Then benign prostatic hypertrophy. Why? Because you already saw alpha 1 receptors are present on prostate. Then pheochromocytoma. So in pheochromocytoma, what happens is we use non-selective ones. Phenoxybenzamine or phentolamine is used in pheochromocytoma. Then we have congestive cardiac failure and peripheral vascular disease. So most of the places alpha 1 blockers are used. Now what are the adverse effects? There's postural hypotension, headache, dizziness, and gangrene of toes and fingers on prolonged use. Right? So you should remember alpha blockers are used in hypertension, benign prostatic hypertrophy, pheochromocytoma, congestive cardiac failure, and peripheral vascular disease. Whereas it might cause, so you'll hear when you prescribe some patient, you see some patient who has been on prazosin. Sometimes prazosin is given. So there will be a first dose effect of postural hypertension. Then you can see headache, dizziness, and gangrene of toes and fingers on prolonged use of alpha blockers. Then comes our beta blocker. So in beta blocker, we have non-selective beta blocker, which are propranolol, sotalol, nadolol, pindolol, and timolol, which acts on beta 1 as well as beta 2. There are cardioselective beta blockers, which are metoprolol, atenolol, S-butolol, ismolol, and bisoprolol. So it is not that in beta actually, it is not that it won't act on beta 2, it won't block beta 2. It is just that it will have lesser effect than these non-selective blockers on beta 2. Then there are beta blockers with additional vasodilator activity. So beta blockers with additional vasodilator activity, because these drugs have effect on alpha receptors as well. That is, these drugs block alpha receptors as well. So they are both beta plus alpha blockers. So these are labetalol and carvedilol. Okay. So non-selective beta blocker, propranolol, sotalol, nadolol, pindolol, timolol. And in cardioselective, metoprolol, ismolol, atenolol, bisoprolol. And with additional vasodilator activity, labetalol and carvedilol. Then beta blockers, they have actually a wide range of action. So beta blockers are given in hypertension, then they are given in angina prophylaxis and myocardial infarction, then in pheochromocytoma. So in pheochromocytoma, remember the order that first an alpha blocker is given, then a beta blocker is given. It's not that you can reverse the order. Okay, because what will happen is if you give beta blockers first, then on blood vessels, what will that be? That it will have an unopposed action of alpha stimulation, and that will cause all the more vasoconstriction. So in pheochromocytoma, we give both alpha blocker as well as beta blocker, but we give alpha blockers first and then we give beta blockers. Then we have cardiac arrhythmias. In cardiac arrhythmias also, we administer beta blockers. Then in glaucoma, we give beta blockers. Prophylaxis of migraine. Then in hyperthyroidism and in anxiety state. So there are many people, if you ask them to come on stage or go on stage, they have anxiety. So if they take some non-selective, say if you have given them propranolol, they will pretty much handle that stress of on-stage fright. Then we have, if we have so many side effects, we have few adverse effects as well. So beta blockers cause bradycardia, congestive cardiac failure and pulmonary edema. Then they may worsen asthmatic attacks. So if you give a non-selective beta blocker, so that will act both beta 1 and beta 2. So beta 2 receptors, they are present on lungs. You saw that it's present on bronchi, in the lungs. So in bronchi, bronchioles, etc. So they may worsen or precipitate an attack of asthma. Then beta blocker will also cause fatigue. There will be rebound hypertension and angina as well. So with this, we have seen that peripheral nervous system has somatic motor part, then an autonomic part. Autonomic part which controls the involuntary movements or involuntary functions of our body, like heart rate, blood pressure, digestion, etc. Then in autonomic system, we have sympathetic system and parasympathetic system. Parasympathetic system actually helps maintain the rest state of the body. And sympathetic system helps maintain the fear, fright and fight. Fear, flight, fight. These three responses of the body. You might have read this earlier also. Then we narrow down to sympathetic system now. So in sympathetic system, we have sympathetic drugs. So sympathomimetic drugs and anti-adrenergic drugs. So adrenergic drugs and anti-adrenergic drugs. So adrenergic drugs, so first to understand adrenergic drugs, we have a few receptors where these things can act. So we have sympathetic or adrenergic receptors. So we have alpha 1 receptors, we have alpha 2 receptors, then we have beta receptors. So we have alpha receptors as well as beta receptors. Now alpha receptors are of two types, alpha 1, alpha 2. Beta receptors are of three types, beta 1, beta 2 and beta 3. Alpha 2 receptors are mostly present in presynaptic junctions. Alpha 2 receptors are present in presynaptic junctions. Alpha 1 receptors are present on vasomotor smooth muscles or vascular smooth muscles. Then they are present on prostate, pupillary dilator muscles, right? Coming over to beta receptors, beta 1 present on heart and kidney, beta 2 present on lungs, then they are present on lungs, then they are present also on vascular smooth muscles, they are present on uterus, and then we have beta 3 receptors which are present on adipose tissue. Then we have a therapeutic classification of adrenergic drugs. So that is, drugs can be classified into vasopressors, bronchodilators, CNS stimulants, cardiac stimulants, nasal decongestants, appetite suppressants and uterine relaxants. The therapeutic uses anaphylactic shock with local anesthetics and control of hemorrhage. Why can it control hemorrhage? Because it will cause vasoconstriction. Then in glaucoma and in shock. Then moving on to anti-adrenergic drugs. So here also, as we had two types of receptors, alpha and beta, will have two types of drugs, alpha blockers and beta blockers. In alpha blockers, you must remember non-selective and selective. Then uses of alpha blockers, hypertension, benign prostatic hypertrophy, pheochromocytoma, congestive cardiac failure and peripheral vascular disease. Then moving to beta blockers, we have hypertension, angina prophylaxis and myocardial infarction. Again, pheochromocytoma, cardiac arrhythmias, glaucoma, prophylaxis of migraine, hyperthyroidism and anxiety states. So, if you get a note, you can summarize these things and your answer would be complete. Okay, thank you very much. If you have any question, you can actually revert back anytime.